This was probably one of the most interesting but testing cases that we had received in our clinics. So, when other departments find it difficult to identify the cause for a particular disease, especially one that involves the liver, we are called in to assess the situation. I have a Department of Hepatology where I look at primary liver diseases, including cirrhosis, hepatitis B, hepatitis C, autoimmune liver disease, alcohol-related liver disease, acute and chronic liver failure. All of them come under primary liver disease where we take care of these patients directly, and a lot of them come through referrals. But then we have a parallel department. I call it my shadow department of medicine, where it's not purely hepatology that we are dealing with, but we are dealing with patients who have a hepatology problem, but then they have a lot more other problems. I want to call hepatology, and I think I may be biased with when there are a lot of other branches, but I think hepatology is the most extreme form of internal medicine, and there is no more beautiful branch than internal medicine, what we call as general medicine. As a subspecialist or a super specialist, I think we should all be internal medicine specialists first, and then we become super specialists. So every patient has to be looked at from an internal medicine point of view, and then focus on what is happening and then target exactly what is happening to them and then treat. So that is why even though I'm a hepatologist and I practice my subspecialty almost every day, I get these cases where it's just not hepatology that we have to think about. It is a patient as a whole, because there are a lot of other systems also involved, and my shadow department of medicine just kicks in. One day we got this call from the intensive care unit, and my colleague, he saw the patient first. He went there and saw that there was this middle-aged man. He was working in the Middle East, but he had come for a holiday here to Kerala, and he was traveling a bit in Kerala, Karnataka, and South India mostly. And he came back after a couple of weeks of family trips, came back to Kochi where he actually stays. And from a few days after he returned from these trips, he started getting a high-grade fever. And this was probably close to 101, 102, and it lasted for about 2-3 days. And then he became very lethargic, and at one point he collapsed at home, because the simple fever medications, even though they were controlling the fever, his other symptoms were evolving, and he was getting weaker and weaker. And after 3 days, he found himself in the intensive care unit. So once in the intensive care unit, the doctors looked at him and saw that this man has some infection. There was a great deal of fever happening, and then suddenly he collapsed and he was very lethargic. He was vomiting. He had multiple episodes of loose stools, loose motions, relentless diarrhea. And other than that, there was no skin changes, no rash on the skin, no eye-related abnormalities. He was conscious, alert, even though very lethargic in the intensive care unit at admission. So they found out that the reason why he collapsed was that his blood pressure was very low. So he presented to the intensive care unit through the emergency in a state of shock. So there was shock happening after a bout of fever, and then patient was quite tired for a while. He was not eating. Then came all the gastrointestinal symptoms where he was having vomiting and he was having a lot of loose motions, etc. And beyond the first 2 days in the ICU, he started getting violent seizures. And the doctors had no other option but to put him on a ventilator, and he was sedated, given these anti-epileptic drugs, and then they put him on a ventilator because his seizures were not getting controlled, a condition known as status epilepticus. So this man, who did not have any disease per se, no diabetes, no high blood pressure, he did not have any thyroid disease, he did not have any kidney disease, no liver disease, definitely no brain disease. First time he was getting seizures in his life. Within 3-4 days, he was on the ventilator. The shock state was still ongoing. They were giving him fluids, they were giving him medications to improve his blood pressure levels. And slow and steady, they saw that his liver function tests were getting hit. His liver functions were drastically worsening day by day, and it started off with his enzyme levels going up to above 2000 one fine day suddenly, which can also happen because of the shock, because in shock the blood pressure is very low and the blood flow reduces, and that can actually impact the liver, whereby the blood flow to the liver also reduces, and the liver undergoes something known as ischemic hepatitis, where due to lack of blood flow, the liver cells get damaged and inflamed. So it could be that, they thought. And this went on for a few days, and then he started developing jaundice. Because in ischemic hepatitis, in pure ischemic hepatitis, the presence of jaundice is quite unlikely. You'll have very high liver enzymes, but usually jaundice does not happen so quickly, and it does not progress so rapidly. But for this man, it was exactly the opposite that we consider ischemic hepatitis to be. So they said, there is something more that we need to check into now that the liver is getting hit. So they looked for hepatitis A virus, because hepatitis A virus is a weird virus. It can actually affect multiple systems together, even though very, very rare. It can cause neurological complications. It can cause autoimmune disorders. It can affect the kidney. It can affect the heart, etc. But then hepatitis A was negative, hepatitis E was negative, hepatitis B was negative. So the actual viruses that harm the liver, they were all negative in this man. And then one fine day they found out that, while his shock state was improving, he suddenly developed worsening shock. And they had to increase the medications for the shock. And his liver functions were becoming worse and worse. And his fever, even though he had fever while he was in hospital, it actually went off in a couple of days after that. And he did not have any fever beyond that. So when my colleague saw him, there was something else happening. And that was that his kidneys were also getting involved. He had kidney damage, kidney injury, and his creatinine levels were going high. So much that they had to put him on dialysis. So all of this was happening in just 24 to 48 hours, and that is when we got called because the liver was involved and they wanted to figure out, if something that we know of harming the liver would be the cause for all of this. But then standard primary infectious liver disorders were completely ruled out by these doctors at the outset, and we did not have anything much to offer. But then we took a step back and looked at what was happening. So there was this person, he had fever, then he had GI symptoms, he had vomiting, he had diarrhea. Then he developed ongoing shock in between this. And one of the reasons for the shock was that his heart pumping was quite poor. He had a heart failure kind of a picture, and that was because of an inflammation of the heart muscles. Overall, globally, we call it as global hypokinesia, where the whole heart is so weak to pump. That was happening. And then his liver gets hit, and then his kidney gets hit. And most importantly, his brain also gets hit. So he has seizures. The diagnosis that the ICU doctors made was something known as acute liver failure due to an ongoing severe infection. Now, the interesting part was that this man did not have acute liver failure, because when we looked at his tests and clinically, to call somebody as having acute liver failure, you need to have jaundice. Okay, this man had that. You need to have encephalopathy, which is brain failure, which is associated with a very high ammonia level. And you need to have a test called as prothrombin time INR going above 1.5. So in him, the INR levels were perfectly normal. His ammonia levels were hardly raised. It was close to about 28 or 30. Not the levels that we actually expect in acute liver failure, which can go even up to thousands. And his brain failure was actually not brain failure per se. It was because he was having seizures and he was sedated. And on imaging of the brain, a CT brain was taken. That did not show any brain swelling. So there is this condition known as cerebral edema, where high levels of ammonia in the blood will reach the brain, and the ammonia will actually attack the nerve cells in the brain and it will cause swelling. And that leads to brain swelling, which is cerebral edema, which was not evident in this man. So this was not a case of acute liver failure, and this was not a case for hepatology to deal with. But then there was something more happening. We looked at his blood test and saw that almost every organ system was getting involved. So his brain, heart, liver, kidneys, and gut was involved. And on top of that, we saw that his thyroid functions were quite low. So the thyroid function test, it contains 3 parameters. One is TSH, thyroid stimulating hormone, and the T3 and T4 hormonal levels. So in him, the TSH was very, very, very low, which meant that his T3 and T4, his thyroid hormone levels were quite high. So this is something we call as hyperthyroidism or thyroiditis. When there is inflammation in the thyroid, the hormones get released heavily, and this leads to a lowering of thyroid stimulating hormone. So when the TSH is very low, we call it as a condition of hyperthyroidism. So his thyroid gland was also involved. What could possibly be happening here? And that is when we realized that he had something more happening. So we saw that during the clinical review of the investigations and the papers that the ENT doctor was also called, the doctor who looks at the ear, nose and throat. So we wondered why was the ENT called for this, So the moment he arrived in hospital, within a day or so, he was not able to appreciate what people were telling him, what the doctors were asking him. And an ENT was called to look for any issues with the ears because he was complaining that his hearing was getting impacted, and they found out that he had something known as sensory neural hearing loss, acute. Acute means sudden onset. Sensory neural hearing loss, which is a hearing loss which is associated with inflammation inside the nerves inside the ear, to put it simply. So he had severe ear inflammation. The nerve cells in the ear was also inflamed, because of which he had hearing loss also. So there are so many systems getting involved here. And there was only one thing that could cause this in an acute situation, that has to be an infection. So we looked at everything that could do this to adults, land them up in an ICU and hit almost all their organ systems, including organ systems that we don't expect to be hit in an infection that involves the liver. And we found out something, and we tested for it. So the test that we did was something known as a PCR, polymerase chain reaction, and that will identify the replicating virus actively in the body. And we sent swabs from his oral cavity from his rectum. We also sent his blood. We sent his bronchial washings, the fluid inside his lungs. Everything was sent for these viral tests. And we finally found the bug that was almost killing him. And it was a group of viruses known as enterovirus. I'm sure nobody would have heard of this, but then we all read about it, but never think about this causing actual chaos in a real life patient. So enterovirus, there are lots of viruses that belong to this group of enterovirus, but for him, in this patient, it was a virus known as Coxsackie. So there is a virus known as Coxsackie virus. There are different types of enterovirus, for example, enterovirus A7. There is another virus known as ecovirus, which are all part of enterovirus group of viruses, and they all are the ones who are implicated in causing severe hepatitis, along with other multi-system involvement. And finally, we figured out that Coxsackie virus was the one that attacked him because it's very specifically attacks the ears also. You have a sensory neural hearing loss with Coxsackie. And ultimately, the whole aspect of treating him became even more difficult because there is no treatment for Coxsackie virus and enterovirus infection apart from aggressive management. So because he was having inflammation everywhere, so there was multi-system inflammation and he was on multiple organ supports, the only way we could actually bring him out was to give him high doses of steroids to reduce inflammation quickly. It's a double-edged sword. Giving him steroids could actually save him, but it can also kill him because by giving steroids, immune suppression can happen rapidly. That can open doors for other organisms to attack him. For example, a fungus, a bacteria, they are all invited to attack the patient once a high dose of immunosuppression goes in. But then we had no options left because he was going to die if we did not do anything. So we spoke to the family members and we said that, this is the only way out. We had to give him very high dose of immunosuppression in the form of injectable steroid. So we would pulse him with about 1 gram of steroid in the first day and then 500 milligrams and bring it down to 250, 200, 100 and then maintain. But we would look at what would happen after the first 2 doses to see if he is improving and then we would take a call on that. But to do that, we needed the consent, the family's consent. And ultimately, the wife, and he had 2 children and they were small children. One was 17 years old and one was 11. If I remember, I don't forget my patients and their family. They all remain with me even after I treat them or even after they die after prolonged illness. And they said, what would you do? That's a very common question that people ask me. And I would say that there is no price that we can put on a life and you have to do what you have to do. If this is the only way out, we have to take that risk because sometimes with the knowledge that we have and with the published literature evidence that we have, this is going to help. So they said, please go ahead. So we pulsed him with 1 gram of steroids in the first day and then put him on a tapering dose of steroids injectable. And miraculously for them, surprisingly but expectedly for us, he improved on the 3rd day. So his inflammatory markers came down, his kidney function started improving, his kidneys opened up, he was taken out of dialysis, his medications for the shock, for the heart, everything came down. He woke up after a week and he did not know what was going on. But at some point during follow-up, I really did tell him what was going on and he was peacefully sleeping on the ventilator while we were fighting tooth and nail for him outside. And ultimately he was weaned off the ventilator and he was in the room for about a couple of weeks for rehabilitation and then he went home. And I met him close to a month later and he was doing fine and he was going back to Dubai to continue his life there and his family was with him. So this was something that we did not expect, but as a hepatologist, I was not expecting this to be part of what we were going to deal with. But I'm happy that this patient and his consultation came to us, to our shadow department. We were able to think out of the box for patients and we do this very frequently. And these are stories for me to tell you in later episodes and I will. And they're interesting even though not all of them are as happy as this one. But I hope you learned something new today, like I learned that day, which I'll never forget, that if there is a multi-system involvement and you consider it as an infection and there is hepatitis and the infection is so rapid that it is taking down the patient quickly along with the liver, and you don't see actual acute liver failure in these patients, which can also occur. There are publications of acute liver failure due to enteroviruses. But if you see that there is no actual acute liver failure and there is just multiple organ failure and the liver is taken down along with the multiple organ failure, please always remember to check for enteroviruses, Coxsackie virus, ecovirus, enterovirus type A7. There are multiple of these enteroviruses that can harm humans and can cause rapidly progressive organ failures leading to death if not treated at the right time. So until next time, with a new story and a new real incident, take care and goodbye.